So I'm going to talk about the exercise coronary physiology. So these are some setup in my hospital, in my cath lab. So this is the angio machine, the Philips, and these are the supine bicycle exercise machine. We can attach or detach when we are using this. And this is cardiopulmonary analyzer. We can control the exercise intensity and measure vital sign, cardiac output, VO2 max, and respiratory quotient using this machine. And after doing that, the analysis, we can analyze those cardiopulmonary exercise parameters using this screen. So these are actual case evaluation. You may saw the patient are running the supine bicycle on top of the angio table. So after getting the baseline physiology, at each step of the exercise, we measure the mean transit time because we don't have Doppler wire. They don't sell the Doppler wire anymore. So we are measuring the exercise mean transit time as a surrogate marker of coronary flow velocity. So the exercise protocol is 20 watt, 40 watt, 60 watt, 80 watt, and 100 watt until the patient reaches the peak exercise, which is measured by respiratory quotient more than 1.0. So these are measurement protocol that I made. And let me introduce our case. I will show you two totally different cases. The first one is 40-year-old gentleman. Actually, he got no chest pain or no symptom at all. He referred from outside the hospital for PCI because of coronary CT angiogram showed 70% stenosis at the proximal LAD. He had previous history of diabetes, hypertension, hyperlipidemia, and interestingly, he was very muscular man and previously professional judo athlete. And as CT showed the proximal LAD, very tight stenosis with the low attenuating plaque, high plaque burden, and the angiogram showed less severe than coronary CT angiogram, but the more than intermediate stenosis at the middle LAD. So these are baseline evaluation, PDPA 0.93 and FFR under 140 microgram IV adenosine was 0.75 and the CFR was 3.3 and this is the typical example of negative resting index but positive FFR with very good CFR value. And the FFR pullback showed major step up across the proximal LAD stenosis. So we did the supine bicycle exercise as a research protocol. So total exercise duration was about 30 minutes. While he is doing the exercise, heart rate rising, cardiac output increased, and VO2 max, you can see the huge increase during the exercise. And at peak exercise, his RQ value is around 1.3, meaning he did very well up to the peak exercise level. After exercise, his lactic acid level was doubled, but within the normal range. And these are exercise physiology results. While he is doing the exercise, the aortic pressure and distal coronary pressure was significantly increased. And under those conditions, coronary flow increased and the microvascular resistance index was much decreased. As a result, the exercise PDPA were gradually decreased until the 0.88. Please remember the pharmacologic FFR was 0.75. So at that time, I was discussed with patient about the treatment option. The first one is medical treatment alone because he don't have any other symptom. And second option is the FFR guided PCI because the current guideline recommend the PCI for the low FFR region, even in the asymptomatic status based on the evidence of myocardial ischemia. So he chose to be treated, and I implanted one stent with the excellent result. And it is a post-PCI result, a resting PDPA 0.94. Please remember, pre-PCI value was 93. And the FFR was increased up to 87 without major gradient. And 1 month later at outpatient clinic, the treadmill test up to 12 minutes of exercise, no abnormality at all. Our second case is a similar age gentleman, and chief complaint is a typical angina chest pain with the dyspnea from since 3 years ago. He was also referred based on the CT stenosis, and he has unique past medical history and family history of sudden cardiac death. And he was kind of obese man, and he did not enjoy physical activity at all. And his CT scan showed intermediate stenosis at the LAD and also another stenosis in the circumflex. These are angiogram, RCA, no significant at all, and there were some small stenosis at the far distal circumflex. And LAD, there were intermediate stenosis at the medial LAD level, and these are baseline physiologic evaluation. And the LAD PDPA was 0.90, FFR 7.6, and the CFR was 2.3, and circumflex was normal in the FFR. So we did the supine bicycle exercise. The total exercise duration was about 25 minutes. As with the first case, the heart rate, cardiac output, VO2 max was increased during the exercise, and his final RQ value was around 1.4, and which means he did peak exercise in the cath lab. And the lactic acid level was, before exercise was 2.3, normal range. After exercise, his lactic acid level was remarkably increased up to 8.0. So these are results of coronary physiology during exercise. As with the first case, the aortic pressure and distal coronary pressure was increased during the exercise, and the microvascular resistance decreased and CFR increased. There were some striking difference regarding the exercise PDPA. Please remember this patient has modest exercise capacity. At the peak exercise, his PDPA level was 0.78, which was very similar with the pharmacologic FFR value. So based on those results, I did the medial LAD PCI. It was simple. And the post-PCI result was excellent without major gradient, and 1 month treadmill test was also negative. So these are case summaries. The left one, no symptom at all, proximal LAD intermediate stenosis, and he did his best for the supine bicycle exercise, but the exercise PDPA never got to the level of pharmacologic FFR. However, in second case, with modest exercise capacity, the exercise PDPA easily reached to the level of pharmacologic FFR. So this is my final slide. The exercise PDPA, which means the hemodynamic status during the exercise, can be varied according to the patient exercise capacity. Exercise PDPA can more easily reach the pharmacologic FFR value in patients with limited or moderate exercise capacity. And pharmacologic FFR reflect the worst case scenario of hemodynamic significance of stenosis in the target vessels. Therefore, decision-making of PCI, I think pharmacologic FFR should be used. Thank you.